All right, so I will introduce our speaker, Dr. Tommy Chan. Um, Tommy is an assistant professor in the Department of Clinical Neurological Sciences at Western, and he is also the director for the John H. Kreeft Headache Clinic at Victoria Hospital. He's a dual board certified neurologist at the Royal College of Physicians and Surgeons of Canada and the American Board of Neurology and Psychiatry. Thank you, Tom. We look forward to your talk.
Hi, thanks for the group for the invitation. I know we had to reset schedule a couple of times due to conflict, but and nice to see some of the faces to the name and name to the faces. I know with a lot of email chains that we have been sent in the group. And so for the next 30 minutes or so, I would hopefully just to go through an overview of migraine in both from a diagnostic perspective, biomarkers, therapeutics, and where we stand actually from the overall treatment landscape of migraine. And I want to highlight these objectives. So hopefully by the end of this short, concise, comprehensive session that you're able to recognize and appreciate migraine itself is more than just a headache. It's a sensory processing problem. When should we order investigation? What are the treatments available? And is actually any role for any biomarkers? This is often my first statement whenever I give a talk on migraines. Often both patients and trainees and both researcher or clinicians often think migraine and headaches are synonymous, but my headache is only one part of the process of migraine condition. And me and Myrna this morning, we went through some of the research, inclusion, exclusion criteria. Migraine is a medical diagnosis. So there's no migraines, there's migraine, and then you can have symptoms such as headache, which is part of your migraine attack. Most of the migraine patients you see have this aspects of very sensitive to things around them. So sound, light, smell, etc. And again, really feeds into this. It is a central nervous system disorder that starts from a peripheral system and then converges to the central system, not merely a pain condition. And so they that really feeds into that it's a brain process rather than just a simple headache process to really have this in a flow chart or diagram for you. As you can see here, historically, we often thought that migraine attack is purely just, hey, there's vasodilation, therefore that people get this throbbing headaches. And then when you take a triptan, like a vasoconstrictive medication, it helps them. So it's actually not that's an obsolete kind of theory because the process of the pathophysiology of migraine process is not as simple as your vasovascular structure is dilating or vasoconstricting. In fact, they've done that when you measure your pulse, when you're having your throbbing headache episodes, it actually doesn't correlate with the pulse. And next time, if anybody of you suffers from migraine and headaches as part of your symptoms, it's actually the throbbing is not the same as your pulse. And it's just the features of actually the neurogenic inflammation. So we are more pushed from, let's say, the year of 2025, we are really more in supportive of a neurogenic theory than a vascular theory. And I know there's still, you cannot really separate the neurovascular connection though. So there's obviously a lot of players involved from the duromeningeal vessels, which is where a lot of the animal trials are carried out. And but that's a release of neuroinflammatory markers. Those are just initiator of inputs coming in. Let's say a lot of the important neuropeptides as a substance P, neurokinase A, CGRP stands for calcitonin gene related peptide, which is a significant and recent therapeutic target, which we'll go through some of the treatments later. And that really, really could obviously have a vasoactive properties, but really it's not as simple as that, right? We know that the trigeminal nerves gets activated, and then once you go through the central process of the brainstem, it's not just a bi-directional up and downstream, right? We have a lot of internetwork involvement that involves a lot of even theories of hypothalamus being the generator before this whole process starts, a lot of intern connectory connection and communication between your brainstem structures, including your periaqueductal gray, the sulcus allureus, and many more. And extending beyond that, even the vestibular system can be involved. The cerebellar system could be involved. That's why a lot of patients could have vestibular cerebellar dysfunction. And obviously, higher up to the brain, we have more higher cortical dysfunction, which that's more patient starts to have some cognitive disturbance that could be seen. And obviously, the primary sensory cortex and obviously the secondary structures could also be involved. So it's not as simple as something in the exterior peripheral system gets activated, comes in and travel up. That's only one part of the pathway. I use an analogy is like it's like the highway 401. And I know that it seems like if you just look at very quickly, it's just a highway that goes from east to west. But you realize in between, there's a lot of turns, a lot of in and out on different entry point, and a lot of ramps. You might see congestion sometimes in the Mississauga region. Sometimes you might see in the Woodstock region, but then that may not be where the accidents or where the actual traffic is starting. And so it's not as simple as that. And often I use that analogy to my patients to really appreciate, to take a step back, to appreciate the pathophysiology of migraine attack is not as simple as that of something sets off something from one side and ends up on the other side. Let's think about the case. Let's say this is one of the typical cases, and this would be actually a case that Myrna will enroll in the trial that we want to for fMRI and EEG, is that patients who is in her 30s, a woman who has known 6-year history of recurrent headaches and all the features that you will see in patients with migraine, sensitive to light and sound, one-sided pain, 6 to 8 days a month, there are considered those days with those features. Well, she takes triptans and it works. But then the current concern, usually they come to clinics because they've noticed that has progressed, meaning that's more frequent now. And then, well, the medications are still responding quite well, but maybe it's a tendency of overusing a little bit. Due to this progression, extremely common in the clinical practice, where although that it sounds like migraine, smells like migraine, but then patients are concerned because of the progression of increased frequency and intensity, and not uncommonly, sometimes acute medication starts not to work. So this patient often may come to a family doctor clinic or any providers and say, hey, you know what, can I get a brain scan because I feel like something's off. This is not typical. And I want you to confirm that I have migraine because I don't really buy it. Like just because you tell me that this is a common problem that affects 1 billion people in the world. So migraine itself, it's a clinical diagnosis, and this is based on the International Classification of Headache Disorder. And again, this is the textbook, and we often see patients outside of the textbook. That's why we cannot be replaced by AI yet, but it will help us formulate that that's the most likely diagnosis they have. They will have to have at least 5 attacks. Duration of these headaches could be 4 to 72 hours. They could fulfill 2 of the 4 characteristics, and I often highlight that they not necessarily have to be unilateral and pulsating. It could just be a headache that's moderate severe intensity, and it's worse with activity. So a lot of times patients get confused. It's like, hey, my headache is not on one side. It doesn't throb and pulse. This is not a migraine. Well, but I asked them, is it bothersome enough? Do you have to take an ibuprofen? If you try to push through them, does it hurt a little bit more? Well, they probably say yes to those latter questions, and it fulfills the 2 of the 4 diagnostic criteria. The next part is about the sensitive to light and sound and nausea and vomiting. You don't need to have both. It's and or. For the photophobia and phonophobia, you do need to have both. If you have an or, so photophobia or phonophobia, the diagnostic criteria becomes probable migraine. And how I often ask patients about this, again, it's how you give them a scenario. If you are in the middle of an attack, would you prefer to be in a place where the lights are bright, screens are bright, your kids are running around and they're noisy, or you rather to be in a quiet, dark room if you can choose? And often they will say that, you know what, I would prefer the latter because I realize my headache does not get worse when I'm in that environment. And a lot of times my trainees would often do not put them ask those scenarios and just ask them, hey, are you sensitive to light and sound? And often they'll tell you, no, I'm not, like, because they still push through them at work or school or managing their kids or at a busy shopping mall. So it's really how you ask the question with the patients to really fulfill the diagnostic criteria. And sometimes you may be dealing with a probable migraine, but more often than not, actually they fulfill the diagnostic criteria quite beautifully. About 30% of the patients beyond the headache, which is kind of building on this sensory processing disorder concept, they could be affected by stroke-like symptoms. And often the first onset of aura, which affects about 30% of migraine patients, will have visual, sensory, and language in that order. Usually visual is about 70% of migraine patients with aura would have that symptoms. Usually it's a crescendo decrescendo phenomena. Headache could come on with it during or shortly after, and then it goes away. So often this scares patients because they think they're having a stroke. And often I reassure them because when this happens, when it comes and goes in crescendo, decrescendo, strokes don't happen like that because stroke happens very acutely and it's very short if it's a transient ischemic attack. Obviously, if it's a permanent deficit, it won't go away either. So there's obviously some nuances of how to take the history to reassure a patient about that the aura symptoms are in keeping with the migraine condition. And of course, it could scare patients when sometimes they could have aura without the headache phase. And so in those cases, you probably still investigate just to ensure you're not missing out something, but it's not uncommon. So the take home is that when you encounter a patient, let it be a research setting or clinical setting, that you don't need to scan everybody. If you're very confident with your history and exam that there's no red flags to suggest a secondary etiology, you don't need to image them. A mnemonic that I often use, it's I don't have a slide on it, but normally I show is we could have a SNOOP. So it stands for S stands for systemic symptoms, N stands for neurological deficits on exam, O stands for old age, new onset headache at the old age. And then the other O is the acute onset, meaning that it's like a thunderclap headache that people concern with subarachnoid hemorrhage. And the P stands for positional papilledema, meaning swelling of the eyes behind the optic nerves behind the eyes. And then also could be pregnancy. And now there's been more addition to the P's, such as post-traumatic headache or painkillers, which stands for overusing medication. One of the kind of gray area I would say is the P that stands for progression, because often progression, it's in this case that I've illustrated, it is a progression, but it was a subacute progression, which is what we could see in patients with migraine if they're going through, let's say, a tough time in life with physiologically or externally, internally, psychologically, and many, many factors. But obviously, if the progression is rapid and acute, that it's a red flag to consider imaging. And MRI is often recommended from a clinical setting. A CT scan is often not adequate to root out the smaller lesion, including space occupying lesions such as brain tumors. So if we do end up scanning people's brain, let's say MRI, often this is what we see. We see that you have white matter hyperintensity in scattered format in the brain in regions that could be small as a little punctate dot over here. It could be quite numerous too. They could be in areas where you have to really look closely to ensure that it's not in the spectrum of demyelination, okay? And so depending on the age and population and the group, you need to have good clinical radiographic correlations to say if these white matter intensities are clinically relevant or not. And the theory behind why migraine patients get T2 changes in their brain is due to a number of factors. There's concept of is the vascular dysfunction, ischemia, because patients with migraine, particularly the aura patients, have a process of cortical spreading depression leading to oligemia. There's some form of vascular compromise, maybe to the brain for the migraine with aura group. Obviously, we know that it's a neuroinflammatory process. When that happens, the cascade of events really there's become a leaky brain, such as a blood-brain barrier becomes disrupted with the altered neurovascular coupling issue. And obviously, often we could see genetic susceptibility to particularly subtypes of migraine patients. Obviously, there are versions of migraine that are monogenic rather than polygenic that would have very specific white matter changes that could have other implication with cognitive disturbance or ischemic strokes and migraine with aura. But those are the very rare ones. So what we know, if we scan migraine patients, more times than not, you'll see these non-specific changes. We don't have data up to date that there is a correlation that the more white dots you have, the more severe your migraine condition is. However, we do have some data to support that patients with migraine with aura tends to have more if their duration of aura is longer, if their attack frequency is higher. But a lot of questions get raised is like, would there be an increase of white matter changes of burden down the road that would be accumulated enough to cause overall cognitive disturbance that we will see similarly to vascular dementia? We don't have data to support that yet. I think it's extremely hard to tease the two things out because we need a lot of serial imaging for patients with migraine as they age over time for years and years and years and years. At the same time, you also have to correct for the confounding variables for aging, hypertension, diabetes, sleep apnea, for not those being a contributing factor, which is commonly seen as we age as well. So at least in the current time frame, we do not have a good radiographic correlations to talk further about and comment further about the T2 non-specific changes in migraine for cognition. But more data to come, and it is an area of interest, by the way, in the field. With the recent conference we went to internationally, and it was a huge topic that it seems to be what researchers are interested in. And I think the reason behind it is because over the past decade, we're truly really moving forward with considering migraine itself. And we'll go into the research aspect, is that migraine itself sometimes carries beyond not just the ictal problem. There's the interictal kind of in between your attacks. Could there be concern or abnormalities noted that could overall affect cognition and neuropsychological function? And I kind of highlighted a little bit about this, and they actually have done a pretty good study. Every conferences you would attend to about migraine, they would always show this paper. Arnie May is a very famous migraine specialist in Germany. And basically, a migraine patients were put in an MRI scanner continuously for 30 days. And this patient had a few migraine attacks throughout these processes, and basically looking at regions of activation. Basically knowing that seems like even before a migraine attack, during interictal or the ictal attack while they're having their headache phase, and afterward, different regions of the brains are activated in different phases. So there's the pre-ictal, ictal, post-ictal, and most interestingly, that was the teaching point or that I learned from this study, is that even before the headache phase starts, the hypothalamus is extremely, extremely, extremely active. And so how does that correlate on this right side to the left side? Is that we know patients often are really focused on the headache phase of that 4 to 72 hours. In my clinic, I often show this because they would acknowledge that, oh my goodness, I actually have all these symptoms even before my headache phase. And a lot of these are related to regions of the brain, including the hypothalamus. And also it could be affecting regions of the cingulate, the regions of the insula, the limbic system, which is like, wow, we never knew that there's this overlap and correlations in what we might see sometimes with people in epilepsy, right? Like that's the same regions that we comment and talk about. And even the word ictal and interictal is what is used in the epilepsy world. So that's very interesting. And why is that important is because therapeutically, one of the newer medication that we use now in the migraine world called ubrogepant was quite interestingly, if they were to treat it during their pre-ictal or prodromal phase, would the success of the freedom of headache within 24 hours be increased and 48 hours and subsequently? What this really showed is that it is. Because in the study itself, and I don't have a graph here, that the pain freedom at 2 hours was only about 20%. If you just take it when I feel like a headache, I take it. But then if you treat it while I feel like, you know what, I feel like something's about to come on, you take it, your chance of absence of moderate severe headache within 24 hours is 46. And so, and then even absence of any intensity is quite sustained over 24, up to 24% over 24 hours. So there's been a huge shift from a therapeutic side where treating early when patients can recognize the pre-ictal phase, it's a huge new concept in the year of 2025. Kind of shifting gear about the EEG aspect, and this it's not of much interest, to be honest. And I think the reason behind it is because the sensitivity and the variation amongst patients are quite tricky to capture. But based on what we have, is it seems like in prior research studies, and the group here could comment after when we do the Q&A, because this is, I would say that at any conferences that we go to, EEG is almost never mentioned from the clinical aspect. There might be some research that's mentioned, but seems like there has been a huge gap from the bedside, from the bench to the clinical. The translational aspect of EEG in migraine still is significantly a huge gap. But what do we know? So it seems like maybe interictally that there's an increased theta activity that we see in certain regions of the brain, occipital or parietal regions. Or during an attack, we might see more pronounced changes like the alpha slowing, maybe asymmetry one side more than the other, some cortical dysfunction, right? There could be some sub delta in the post-stromal phase. But as mentioned, there's so far globally, EEG has not been utilized for any clinical routine diagnosis because the diagnosis of migraine is clinical. You don't need MRI or EEG. The role remains still in the research now, but this may be something to consider in the future. Could this be a format of biomarker for patients who may have other conditions, or you want to support your clinical diagnosis? And so this is still to be determined. What about other biomarkers? We talk about MRI, we talk about EEG. So, right, imagine a case that I presented, you reassure that patient, your progression is very, very reassuring. You still check off all the boxes for migraine diagnosis. It's just more frequent now. They asked about biomarkers. We went through the MRI, we went through the EEG. And let's say that they did go order an MRI because the family doctor's hands are tied and they have to order them. You explain to the patient about these non-specific T2 changes, what they actually means. We talked about, okay, are there any other tests? We talked about EEG is still really predominantly in the research aspect, but not clinical. Are there other biomarkers? Well, CGRP, because it's a huge, it's a neuropeptide of interest for the therapeutics. Can you actually measure them? Actually, you could. The problem with it is that the half-life is extremely short. So there's no way from a clinical practice perspective that you can measure from blood and saliva. They have research publication for both that the baseline level of CGRP in migraine patients are elevated when you obtain it from an assay from saliva or blood. And then when you treat them with an agent that blocks it, it comes down and it correlates really well with the CGRP level and the improvement of their symptoms. However, because of, again, the application is very difficult, and two, CGRP is not specific, meaning that people with fibromyalgia, people with chronic pain problem, for other issues, CGRP could be falsely elevated or lowered by other medications they're on, or also elevated by due to other medication. So it becomes extremely difficult to measure in an uncontrolled environment, which is clinical practice in the real world setting. Other markers have been of interest, but it's again very non-specific. So the nerve growth factor, glutamate, inflammatory marker, CRP, TNF alpha, interleukins, extremely non-specific. We just know they're involved. One thing I would say that's of area of interest is the PACAP, which stands for pituitary adenylate cyclase polypeptide. There's been a phase 2 trials that's shown that by blocking it, actually, again, similar to the CGRP blockade, patients do better. And there seems to be some unique features to this marker that is different than the CGRP, but some similarity, but some differences. So something that we foresee that potentially in 2030, there will be a commercially available product that targets specifically on PACAP because of an ongoing phase 2B trials going on right now. I just want to plug this because we have a group here. Obviously, all these are over my head because this is the research aspect of what David's and your team and your group has done. And I just really want to highlight that I'm sure that you're all familiar with these key regions that I know the group here are quite interested in, the claustrum and also the inferior dorsolateral prefrontal cortex. I know that the research group here has identified that these regions could be really involved from a cognition perspective, particularly even during interictal phase or during cognitive tasks. Also knowing that potentially the cortical motor excitability and the peak alpha frequency seems to be affected lower when they are doing performance associated during cognitive tasks, and then could potentially be a marker to see if these patients are going to be indicator that would transform to chronic pain down the line. I know there's positive trials looking at the TMJ from David. You have mentioned when we initially met, it was based on your, I think, 120 or 150 patient that you were able to identify this as a marker for the TMJ population. And I think now that really is we want to see if how this could really translate to the migraine population. And right now, ongoing research with Dave and Myrna, we're looking and enrolling episodic migraine patients, looking at enrollment of EEG and fMRI findings for these patients, and we're in the midst of recruitment. And so that's still to be determined. And I think that, again, I'm looking really forward to the collaboration because, again, I think the biggest gap in the migraine field has always been the translational aspect. And even when we go to conferences where we go to the scientific meetings versus the clinical meetings, it's very disjointed. And I'm looking forward to the collaboration and see what we can what the outcomes will be during this process. So the last part of my presentation is really kind of give you a sense of the therapeutic aspect. How do we manage the symptoms? Well, simple division is that most of the times we do treat the headache. And I think because that's usually the most bothersome symptoms. But now that we have these pre-ictal symptoms allow us to treat early and recognize and educate patients on the condition overall. For acute treatments, really when you propose a treatment for patients, you want them to be able to return back to normal functions. They could tolerate the medication and they could achieve pain freedom. The prevention aspect, we really want to decrease the overall burden of their headaches or the migraine symptoms over time. And there's different category. I want to take you into a journey of what we have over the years. And this is based on the US time frame, is that we, since the early 1920s, we have the really non-specific ergotamines to the semi-synthetic form of dihydroergotamines to the triptans in the early 1990s. And then fast forward in the last couple of years, we're using the gepants, we call them, which block the CGRP neuropeptide that's heavily involved in migraine process. The triptans overall, we have 7 of them. They work pretty well overall. Pain freedom is about 20 to 40% if you take them during when you notice there is the headache. And there's some nuances between the half-life of a lot of these medications that usually they peak kind of at its 1 hour mark. If you use subcutaneous form, obviously it's a bit faster. The problem with a lot of these older generation migraine medications, tolerability is not the greatest. Almost up to 47% of the patients will complain about some degree of side effect. Therefore, this new category of medication, the gepants here, in fact, the side effect profile is less than 3%. We have 2 of the agents available. As I said, ubrogepant did a lot of trials looking at treating a prodromal phases, pre-ictal phases, treating early. Rimegepant came out a bit later, and it's a longer acting version, and there's this integration tablet. They both have indication for acute treatment. And as I previously mentioned, the pain freedom at 2 hours is about 21% or so. And if you treat them early, the sustained pain freedom is up to 24%. And usually the numbers is usually not that sustained if you don't treat it early. You're down to less than 10% if you treat it late. Interestingly, MBS stands for most bothersome symptoms, is a really nice marker from clinical research since 2019 that beyond pain and headache, they ask patients, what are your most bothersome symptoms? Usually it's photophobia, phonophobia, and then nausea are the top 3 of most bothersome symptoms that really, again, recognizing that migraine is a sensory processing disorder, not just headache. Headache is only one part of it. If you look at the prevention side, we have a lot of treatments available, right? The tricyclic antidepressant, the beta blockers, and the anti-seizure medication. And we look at the mechanism of these medications. In fact, it's quite interesting. You know that they're quite non-specific, but you look at this column here. Most of them are actually targeting a lot of the players that we're quite familiar with in terms of the serotonin system, the noradrenergic system, the GABAergic system, the glutaminergic system. So it's all about the balancing between a lot of these agents when we use these, the rationale why we use beta blocker, isn't it? It's a blood pressure medication. Why are we using an antidepressant, right? And so it really stems from there. It's a mechanism behind it over the years of why these agents are utilized. The problem with these medications, as you can see, the average reaction is quite long. In fact, most patients, if you put them on this medication, 1/4 of them would discontinue by 6 months, and 1/6 would, 3/4 of them would discontinue by 6 months, and then 5/6 of them would be discontinued by 1 year because of compliance, side effect, and lack of efficacy. And so that's why recent years this CGRP becomes quite of an interest of target, because all the other former agents are quite non-specific. The newer therapeutic target is very specific. We call them the migraine specific target treatments, blocking the CGRP, which is found almost everywhere in the peripheral and central nervous system, particularly the trigeminal cervical cordalis complex convergence pathway. And obviously in the dural aspect, we see that in the meninges, there's a lot of connection between the vessels and the nerve endings as a communicator with the CGRP. We know that if you infuse them, you trigger a migraine-like headache. If you block it, they get better. Last year, the Canadian Headache Society published a guideline on, because we have so many new agents now, we need to reamp not just the anti-seizure and beta blockers or anticonvulsive medications. How do we incorporate in clinical practice of these newer target agents? Basically, this is a busy slide, but I just want to highlight a few things. Is that all the names that ends with a MAP and then the GPANs are specifically targeted to the CGRP. And so they're all highly recommended with strong, great evidence to achieve prevention for patients both in the episodic migraine and chronic migraine group. And so a lot of the older generation medication remains recommended, but again, they just did not change it because there's no new evidence since 10 years ago, which was the previous guideline in 2012. And so they just kept the older generation medications based on prior evidence. But we know actually through a number of studies that the newer agents are more migraine specific. The tolerability is way higher and the discontinuation rate is way lower. And how we look at this overall, if you combine all the migraine treatments now, so the acute, the prevention, now that we have a CGRP targeted, we're looking at basically, if we zoom in the trigeminal nerve and the vasculature, presynaptically and postsynaptically seems like we can really use the CGRP as a target of blockade. Interestingly, even triptans actually or those as serotonin agonists, but nobody talked about this 30 years ago, but it was part of the mechanism. Because of this presynaptic blockade, that actually blocks the downstream of CGRP release, which now we have the GPANs actually blocks the ligand and the receptor, and all these actually are really blocking all the chaos that's happening within the trigeminal vasculature. We have onabotulinum toxin. Just wanted to do a little plug to this because we have this for more than 15 years now, where it's a protocol that rejects around the head, upper neck, and shoulder, which is really targeting a lot of this peripheral nervous system. Although the landmark is at the muscles, the mechanism of how it works is actually causes the SNAP25 cleavage, reduces synaptic acetylcholine releases, also reduces the CGRP downstream, also reduces TRPV, which is obviously a receptor involved in a lot of pain processes, the receptors to be at the nerve terminal. Basically, all these work in the peripheral system and indirectly prevent centrally any of the process that may have the downstream effect. So onabotulinum toxin works really, really well as well, which again overlaps with a lot of the treatments historically, but also the new CGRP targeted treatment as well. And it's not as simple as that it paralyzes muscle. It actually has a neurogenic effect. So now we look at kind of overall, if you combine all the treatments we have available from a prevention, the new stuff, we know that for pain itself, C fiber and A delta fibers are involved in the peripheral nervous system. And then these all converge centrally to the high threshold neuron and the wide dynamic range neuron centrally. And then a lot of these agents, including all the monoclonal antibodies as mentioned, or the GPANs, or the onabot, they all block either the receptor, the C delta, the A delta fiber, receptor ligand, again, they're all really trying to block the peripheral system. Therefore, this downstream effect gets minimized. And this is my last slide. So in summary, again, really highlighting migraine. And again, if you ever have a chance to talk to any patients, is that it's more than a headache. It's a sensory processing disorder. Imaging from a clinical setting remains to be ruling out other red flags rather than actually making the diagnosis of migraine. We have a lot of treatments available. We have the new class now that's very migraine specific. And then we have all these monoclonal antibodies that also are migraine specific. The future direction, again, how do we kind of match the research and the clinical aspect? I think that from a biomarker research perspective about functional neuroimaging, EEG, and cortical signatures, could that really more, rather than, in my opinion, to focus on helping diagnosis migraine, is really predict, in my opinion, has a utility on monitoring or to know if, let's say, a few reasons, could they be responder to these therapeutic targets? Two, can we predict somebody who would develop from episodic to chronic pain or persistent pain? Could we learn this to extrapolate this to other headache conditions? And so a lot of these could really help guide therapeutic responses rather than help establishing the initial diagnosis. That's the end of my talk, and thank you for your time. And I think we have a few minutes for discussion.